to make sure of. Very good. And then there is the other population. They are elderly, 65 and above, and mainly we see it with male. Okay, so fair هذا الدرug أو هذا disease, male and female. Okay. Now, as I said, it involves autoantibodies directed against post-synaptic acetylcholine receptors, which induce T-cell-mediated destruction of this receptor. Once, the interesting part about our body is that they know the self. They know the self molecules. Okay, and so anything, that's why with the babies sometimes, even naturally, the immune system is a bit weaker, just to make sure it accepts the baby, because even the baby is a stranger to the mom. Okay, it's some foreign molecule. Okay, which molecule? Okay, so once there is a foreign molecule, the immune system will be awake and will lead to an immune response to inflammation, destruction, and war will start. And so imagine when self is the enemy. We can't get rid of the self, can we? The receptors are there, we can't do anything. So we suffer. There is some, I'm not sure this is why, but there are regions in Europe and North America, it's more prevalent there. There's more prevalence among women and people in regions such as Europe and North America. Okay, now, what does it involve? The most significant thing is the ocular. The ocular muscles become weaker, so we always see the eyelids being weaker, okay? But also, it can expand. يعني نحن we call something ocular myasthenia gravis. We call it like this. It's categorized like this. But then this doesn't mean that in 2 years it will move to a generalized myasthenia gravis, where we will see involvement of the limb, the respiratory, يعني بصير في weakness بالlimb, the respiratory muscle, which is very dangerous, respiratory muscle, يعني you can't breathe, and the bulbar. The bulbar is the facial muscles, the jaw, the tongue, the weakness, بصير weak of talking, we can't speak very well. So that's it. Now, just to look at just a reminder, and I'm sure you know it, which is the neuromuscular junction, where we know that presynaptically we release acetylcholine. Once released, and in the vicinity of the neuromuscular junction, it should bind to nicotinic receptors, and nicotinic receptors is coupled to sodium channels where it opens, leads to RAND receptor contractility, action potential. Here we go, we have a muscle that's contracting. Now, where's the problem? Here we go. The problem is in the presence of these antibodies that identifies the acetylcholine receptor as antigen. صار في عندنا antigen, antibody reaction, and attack. And so that floating neurotransmitter, the acetylcholine, is not able to bind to the receptor. As a result, we have no muscle contract. Okay, that's the whole concept. Hala, is that the only protein or receptor that's involved in myasthenia gravis? And no, there are others. So I'm just giving you an introduction. I know you've taken it, right? Okay, so it's clear. You can take Tacrolimus?
No,
You're gonna take it
this afternoon.
So what, settle down. So what happens, because my lecture came first, I have to give introduction. Otherwise, you will not understand. So everyone will say, why she's giving us this? It's just, I cannot explain the pharma part before I give you some background. Maybe in the future, we can work on it to coordinate that the patho should come first, then pharma follows. But okay, so again, this is exactly what I'm saying, so I don't need to repeat myself, but we explained it on the image, cartoon image that we have. So this is it. To diagnose myasthenia gravis, they look into the antibodies. They measure anti-acetylcholine receptor antibodies, or it's called muscle-specific tyrosine kinase. Fine. But also there's a nice test that we pharmacologically they do something that's called, written here, it's Tensilin test. Tensilin test, basically they use a drug, it's called hydrophonium. Hydrophonium. Okay, so what is hydrophonium? Tell me. Exactly. So, but it's a short-acting, very short-acting acetylcholinesterase inhibitor. So when the acetylcholine is released from the presynaptic terminal, okay, it's supposed to bind to the receptor, leads to action potential muscle contractility, but then done. Halas, the job, thank you, we'll send you your check at the end of the month. So we break that acetylcholine to, we break it down to inactive components. Using the enzyme, it's called acetylcholinesterase. Cholinesterase breaks it down, okay? Now, if we give an inhibitor, what does that do? What it does is it keeps the acetylcholine for the longest time, for a longer period. Yeah, Shabab. So they use this to see, okay, what if I give a shorter acetylcholinesterase? What will happen? So because we said that the ocular involvement is in the myasthenia gravis is very clear. Yani they see it in most of the cases of myasthenia gravis. So they look at people given hydrophonium. What do they see? What do they expect them to see? Improvement in the this loose eyelid. So look, can you see this? Is that clear? So look, after hydrophonium, so before it was like weak, it's going down, one eye is going down, but after that, there's an improvement. Now, if this did not happen, this could be one of the reasons we can exclude myasthenia gravis. If we did not see improvement in the muscle contractility, this could be a reason, one of the reasons we can exclude myasthenia gravis as the reason behind this. Okay, now back to types. We've mentioned types, but what are the types? First one is ocular myasthenia gravis, MG. Ocular myasthenia gravis. Mainly, they see ptosis and diplopia. شوفوا البيتوسس اللي هي drooping eyelid. This is well seen. Or the diplopia. Look at the hand, we see it double. Okay. Now, we see that most of them, خلاص, that's it. That's all the symptoms there is. It's the طولي بالك. أعطيني فرصة. اتصل بصديق. Okay. So this could be the this could last. يعني that patient can have ocular myasthenia gravis and can stay with that and no complications, no generalized myasthenia gravis. We see that, okay? And usually after ما بضرب بس يوم الخميس صح تفضل بس عشان خلص عشان يعني we're close to finals ولا لا؟ Okay. So 50% of these patients who start with 50. So every time there's noise, I'm going to stop. How about that? 50% of patients with myasthenia gravis develop the generalized disease within 2 years of onset. معناته what they have noticed after the 2 years, basically we can say that we're going to continue having the ocular one. It's going to be the mildest, and that's great. Okay? These patients usually respond to steroids and steroid-sparing immunosuppressant. هلا بدنا نحكي what I use. I'm just ahead of my time. Okay? No need for the other urgent drugs such as intravenous immunoglobulins or plasmapheresis or thymectomy. Now, keep that idea. I'm going to explain it in detail. Don't freak out. The second type is called the early onset generalized myasthenia gravis, which, as we mentioned, attacks female at an early age. So it's more prominent or predominant in females rather than males. And here we have involvement of the thymus. So they have seen with this population of patients, the thymus بصير في عندنا hyperplasia, and so surgically removing it is a good option. Okay? So when if you surgical involvement. First, that's the second, and the third, the late onset, only the second involves the thymus. Has been, we're not talking about 0%, but most probably it's the second part that involves thymus hyperplasia. Okay? So this here we see involvement, the bulbar involvement, as we said, dysphagia, dysphonia, facial muscles, okay? And severe cases, respiratory muscles are affected. Now here, we have to be very careful when we treat. First of all, because these are, as I said, childbearing age. I have to work with teratogenicity. The third type, شوفوا أنا حطيت late onset. This, yes, Ron? Okay, so the third type, which is the late onset generalized myasthenia gravis. Look, this is a head, usually green, young, in the middle age. The late onset is the red one, where we have, it can be misdiagnosed. This category can be misdiagnosed because elderly, there's a lot of comorbidities, and you can miss it. That's what I mean. Okay? So there is other age-related comorbidities, diabetes, heart disease, hypertension, obesity, and osteoporosis. The thymus is not involved, and it is misdiagnosed, as I mentioned. Here, when we choose the drugs, we have to make sure we consider the comorbidities of these population of patients. And I said men have more the late onset than women. طيب, pharmacotherapy of myasthenia gravis. There is something called standard therapy. This is very important. Under it is the group of drugs which we have touched on, cholinesterase inhibitors. Okay, and then supplemental immunosuppressants. This is the second thing. Supplemental immunosuppressants includes two: the glucocorticoids and I think you've taken them in rheumatoid arthritis somehow. Non-steroidal immunosuppressants. Do you remember them? Non-steroidal immunosuppressants. There's مش NSAIDs أكيد. Like Azathioprine. Yes. Okay, so glucocorticoids, alternatively Azathioprine, mycophenolate mofetil, cyclosporine, and tacrolimus. هذول non-steroidal immunosuppressants. هذول بسموهم ايش؟ standard therapy. Okay? هلا second بحالات البيك بالurgent cases we give another regimen. We start with the cholinesterase, with the glucocorticoids, and with the immunosuppressants. Okay? The third category is just new. It's coming somehow biologics. Biologics are drugs that have been recently tried, and they found that they work, and they are getting their way into the myasthenia gravis regimens. Okay? So, this is the second type. And urgent cases يعني في عندنا مثلا involvement of the respiratory, في عندنا severe symptoms. We need to treat urgently. We need something time sparing. We start with something called intravenous immunoglobulins. It's not a specific immunoglobulin. they basically, they extract it from more than one patient, and they make a mechanism is not very clear, but the onset is short, and they do improve the symptoms for a short period. Some of them intravenous immunoglobulins. Alternatively, they do something called plasmapheresis. What is plasmapheresis? كأنه عم بعمل cleaning للantibodies. I'm just filtering the blood from antibodies, and I'm trying to introduce, to minimize the amount of, بس هذه, this is, the faucet is on. There's productivity, there's production of autoantibodies, right? So shortly after, this thing will resume. But it's for the severe cases where I have to do it. Okay, so these are the two things. I will repeat myself. In terms of urgent treatment for temporary relief, I will use IVIG, which is intravenous immunoglobulins, or plasmapheresis. Okay, so studies have shown that intravenous immunoglobulins are well preferred, better results, less complications. That's why it's first. Then plasmapheresis is our second option. They are effective in severe myasthenia gravis until immunosuppressants become effective. We will talk about it. Okay, so we are giving a line of treatment that takes time to kick in. So meanwhile, if there is an urgent attack or a severe attack, I might give intravenous immunoglobulin to help during that period, as I mentioned, until immunosuppressants become effective. So both methods, whether intravenous immunoglobulins or plasmapheresis, they are used pre and post thymectomy. مش قلنا في surgical intervention بالearly generalized myasthenia gravis. قلنا إنه usually this population of patients, they have the hyperplasia of the thymus gland. So we do thymomas, surgery is very good. Pre and post, we can use IVIG. Pre the surgery, post surgery, it is preferable to use IVIG. Okay? Now, the plasmapheresis, we said, requires access to good veins and specialized hospital settings, so a bit more complicated. That's why they will prefer intravenous immunoglobulins. The third group, this is the new one, as I said. يعني نحن في عنا standard therapy وفي عنا urgent treatment. So عنا standard therapy starting. Urgent treatment might be used in between, and in case, this is the new thing, which is the biologics. Biologics, في عنا two drugs for today. They are both monoclonal antibodies, promising, this is the beginning. We're still in the beginning. Promising in the treatment of refractory myasthenia gravis. يعني we have a well-controlled patient, and all of a sudden there's a refractory, then they will go for two monoclonal antibodies. One of them is still not approved. However, I decided to talk about it today. Okay? The first اسمه Cyclosporine أو أكلة زينب. نرجع لزينب. فإكلوزين يعني زينب ما بعرف from what country, بس Syrian يمكن إكلو ما بعرف, I don't know, بس I'm trying to help. Cyclosporine, and the other one is rituximab. Rituximab depletes B cells. It's an off-label use. Off-label يعني till now it's not FDA approved. However, physicians are trying it, they're using it, they're getting very good results. Okay? طيب, let's start. This is all introduction. Basically, I went through all the material of today's lecture. Now the details. It helps you memorize, helps you when you leave from here, you don't need a lot of revision. Okay? So, okay. So again, standard therapy, example, anticholinesterase drugs. What they do is they block the cholinesterase enzymes, which makes the acetylcholine in the vicinity of the neuromuscular junction stay longer time. They have found that this symptomatic improvement is that they use listen, we have to remember this is an autoimmune disease. معناته في dysregulation بالimmune system. Okay? So the source of my disease, I haven't solved it. I haven't solved it, but I'm trying to help symptomatically. First of all, very short onset of action, so I can see some help. Okay? And mechanistically, it makes sense. If I keep the acetylcholine in the vicinity of the neuromuscular junction for a longer time, this will lead for يعني نحن ما عندنا 100% attack on the acetylcholine receptors. We have some attack which is affecting the muscle contractility and strength. And so whatever is left unattacked can work with this. Okay? Acetylcholine can bind and contractility and muscle activity will be improved. Clear? Okay. Now, I'll take you, so this is what I mentioned up. This is the writing part. But here are the types of acetylcholinesterase. The first one, hydrophonium, we don't use it. It's short-acting. Okay? So what is there? Whatever I highlighted in red, اللي هن anything methyl gravis لأنه هن يمكن they will not use them all for the treatment of myasthenia gravis, but neostigmine is used. Okay, pyridostigmine is my optimal option. Okay, along with dystigmine. Why my optimal option? Just for the duration of action. لأنه neostigmine is very short acting. Very short acting. I prefer to give something longer acting, okay? Hydrophonium, we said it's used for the diagnostic part. And physostigmine. Physostigmine, why I'm not using it? For the simple reason that it does cross the blood-brain barrier, and I don't need that. My disease does not involve the CNS, okay, and I don't need to take it to get adverse effects in the CNS. However, I would give it as an antidote for atropine toxicity, okay? So that's a different. So we're clear? My main drug here is pyridostigmine, not physostigmine. Pyridostigmine. Neostigmine is a short-acting. I would prefer to give pyridostigmine. They start with 30 milligrams. I don't give dosages usually, but they usually start with 30 milligrams. But then once we reach 60, and they try to taper it up and increase the dose gradually, once they start giving 60 and above, it's basically time, you know what, we need to include other drugs. We need to include glucocorticoids and immunosuppressants. Hala. What it was difficult for us when we looked at the literature. There's different practices. Some people, they start from the beginning, together, the cholinesterase inhibitors along with glucocorticoids. Okay, because they know that we're talking about a dysregulation of the immune system and we need to fix it early on. Okay, some, however, some wait. Some start with the cholinesterase, improve the symptoms, and then move on when they feel necessary. Okay, now let's go for the adverse effects. Adverse effects, diarrhea. Why diarrhea? Hona, you're going to help me. Why we're having these adverse effects? No. Take me back to the autonomic nervous system. Huh? Okay. So when I have a parasympathomimetic effect, parasympathomimetic effect. What do we expect in terms of symptoms? Parasympathetic like, yeah. GI, bradycardia, salivation, definitely. Sweating, lacrimation. Yes, meiosis, yes. So this is all consistent with a parasympathetic symptom. That's it, okay? And sometimes, bronchoconstriction, oh my God, asthma patients, here we go. Emesis. ليش الجي اي activity صارت so active. That's what the literature says. That's how we explain it. Here I'm not able, but this is the symptoms. Clinically, that's what they have seen in people given cholesterol. Okay, sweating, and here we go. This is it. This is how we're gonna memorize it. It's dumb be less. Dumb be less. Dumb be less. أو صح؟ dumb be dumbbells. Okay. ليش dumb؟ بس dumbbells مش double B أو dumbbells. 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 less. ما في. Okay.
That's down, right?
Now listen. هلا, what about toxicity for people who are taking an overdose of cholesterol inhibitors? Huh? So what they do, we call it بسموها cholinergic crisis. بس that's very rare. لما بصير في عنا overdose of cholinesterase inhibitors, okay? They go under something called cholinergic crisis. Part of the cholinergic crisis is muscle weakness. Now, طب احنا الديزيز تبعنا our disease بيعمل muscle weakness. طب how do I know? How can I tell? Before I tell you this, when there is toxicity, they would give something called glycopyrrolate. Okay, so these adverse effects, they can be controlled by administration of anti-muscarinic drugs. It's called glycopyrrolate. It's mild, it's effective, and sometimes they would give it with the dose. Okay? Now what? So we said, sometimes very high doses, we see muscle articulation cramp, but this is less observed, but this is in overdose. سموها ايش؟ cholinergic crisis. This is cholinergic crisis. It's a major side effect of excessive anticholesterol medication, difficult to distinguish from worsening myasthenia gravis. They both involve muscle weakness. Help me out, Kalla. How can I tell the difference? I can't be response and response. هلا I'm gonna answer you and I'm gonna answer. He is taking cholesterol, but the cholesterol, if it's not working, you will get a myasthenia gravis. Okay, and if you're taking overdose of cholesterol, you will also get a muscle weakness. So what do? How can you tell the difference? Come معي ها. Test forget about that.
Other side effect of the drugs will also be
Okay. Okay. So what? Yeah, flip the point. Let's see. If I have lacrimation with cholinergic crisis, احنا قلنا في عندنا toxicity وفي عندنا overdose والsymptoms عندنا هذا dumbbells. So what should I see? Okay, parasympathetic symptoms, that's true. And I should not see them with the myasthenia gravis crisis patients, right? Check on the Julie? Correct. Okay, you will give for the cholinergic crisis, you will give a glycopyrrolate. But I'm just trying to let you know the difference, how you can see it. This is the myasthenia gravis. So when we define myasthenia gravis, we say exacerbation of the disease process, but that it involves respiratory muscle weakness, severe enough to necessitate intubation or delayed extubation. Okay? في عندنا intense muscle weakness, which is an overlap with the cholinergic crisis, and look here, before I move on, I'm going to show you the thing. Look, certain things, certain diseases, certain situations will increase
the crisis of myasthenia. One of it is if we have this type of infection. But the other thing is pregnancy. So pregnancy can, we can say, can make the effect of the drug a little bit less. لأنه the pregnant woman and the volume of distribution شوي أعلى. Okay, so maybe the activity of the drug could be modified. So they have seen the first trimester of pregnancy and postpartum a crisis increases. Probability of someone with myasthenia gravis to got pregnant. Okay, they have to monitor mainly the first trimester and postpartum after delivery. Okay. طيب هلا التيبل اللي حكينا عنه. So in myasthenia crisis, it is abnormal. In cholinergic, it is uncomplicated. Sweating is absent, but you have sweating increase in cholinergic crisis. Normal heart rate, on the other hand, normal secretion and increased secretion. And the main one, remember, that excellent test, triclexillin test. If it is improvement with excellent test and worsening with excellent test. Okay?
So what the myasthenia crisis, that means that the drug is
The drug is not working.
when you have the overdose, we have the cholinergic.
We can have two scenarios, they're not the same. We have a population of patients who are taking cholinesterase, and for some reason they took the overdose. Right? Not the myasthenia crisis. We have another population, for some reason, they're taking cholinesterase inhibitors, not necessarily high dose, but they got a surge from myasthenia gravis crisis. Okay, so two populations. You got it? Oh, doctor?
What's the difference in pathophysiology of both crises?
The first one, not the pathophysiology. The first one is severe toxicity of the drug. The other one is the disease progress. Okay? Hello.
So the last one is
الانتيدوت اللي هو ايش؟ لاك بايروليت. ما هي انت يعني مرات you don't put the toxins in the body, it's not necessary. Okay? If you put lactopyrrolate and you don't, it's not cholinergic crisis. Why would you do that? That's the treatment. Yeah, this is the involvement of the treatment persona. You would see that even it worsens it. Why? It's another cholinesterase inhibitor. You're giving another cholinesterase inhibitor. Right. Okay, let's move on. We still, oh my God, no way. You have another lecture? No. Break. Okay, so I'm taking 10 minutes. I talked a lot, but I think we can move on easily. The material is all covered. Now, the second standard regimen is glucocorticoids, okay? They, as you all know, it's anti-inflammatory. Hello, guys. Is that working? لازم أعمل هيك بس بضلني هون. امشي. So you all know this. This is a repetition. Glucocorticoids are used as an immunosuppressant and as anti for inflammation, immunosuppress the immune system. It also helps in fighting the infection and decrease certain antibodies. Okay, harmful. Look, yani I've been giving so many lectures, and whenever I involve, all the pharmaceutical companies, all of the physicians, all of them, they try to spare glucocorticoids because of adverse effects. But still, يعني العشق الممنوع عن جد. Because they still go back to it, and after all these years, they feel that it works. And if it works, we're going to use it. Okay? So, it's still considered as first-line therapy. And
what they start to do, when they give cholinesterase inhibitors and they move to glucocorticoids, they start with high doses. But giving high doses, like abruptly, is going to really actually increase the surge, increase the myasthenia gravis symptoms. So they found out that doing it, regular and increasing the dose, gradual increase of the dose, where you reach the peak and you stabilize it, then you try to taper it down a little bit, and then when it's settled, because you want to give the minimal dose, and then you would include other immunosuppressants. Did you get me? I'll repeat. When they start the regimen of glucocorticoids, it's a big no-no to give a high dose initially. You should start with, for example, 20 milligrams and start increasing by 10 milligrams every week until you reach, for 6 weeks span, let's say 8 weeks span, you give to high dose. And later you want to include other immunosuppressants. You want to include other immunosuppressants because you want to replace the glucocorticoids. This is how they think about it. So what they do, they start tapering down. Again, you don't give with high doses glucocorticoids other immunosuppressants. You try to taper down, and when it is minimal dose and settled, you start to include the other immunosuppressants. So let's repeat. First of all, what they prefer to use is oral prednisone. Oral prednisone is a prodrug. Remember, oral prednisone is a prodrug for prednisolone. So it has been found that it's very helpful in tubular myasthenia gravis. Again, as I mentioned, gradual prednisone escalation is essential because they found that 30% of patients, they experience transient worsening if high doses are given from the beginning. Okay, this is again repetition, 10 to 20 milligram every morning, you increase by 10 every week for 6 weeks. This is important. I have to give this dose because we have to keep in mind we never give initial high dose from. Now, alternatively, if patients have liver issues, you better avoid the prodrug and the enzymes from prodrug to a drug. So you would give either prednisolone or methylprednisolone. The side effects, we all know it. We're not going to repeat it because of the time. And they try to give alternatively immunosuppressants. This is their preferred go-to, okay? So the glucocorticoids, as if someone has prepared the place for you and now you are ready to take over. Okay, prepare the body because it helps with the immunosuppression, with the symptoms, with the patient, and then immunosuppressant should take. So what is immunosuppressants? What are the immunosuppressants that we need to think of? First of all, azathioprine. And azathioprine is very important as an immunosuppressant. It's non-steroidal. The issue with azathioprine is highlighted. 12 months, it takes 12 months for the azathioprine to kick in. Okay, so this is something we need to really be careful. It's a long-term treatment. Okay, now azathioprine is a prodrug. Azathioprine is a prodrug, and the mechanism is antipurine. هنا دخلنا وين? We went to the DNA. We're telling the B cell and T cell, you know what? You're really going crazy. You're dividing like no tomorrow. You need to stop. So the azathioprine, they work by decreasing the productivity DNA and RNA so they can lead to apoptosis of B cells and T cells, which are responsible for the myasthenia gravis. Okay? So we're being very, very specific. It is not teratogenic. Not teratogenic. Now, with high doses, you might see miscarriages. You might see some teratogenicity with very high doses. But in general, when someone is pregnant, they would use azathioprine. Clear? Okay. I want to just be talking about the mechanism of action and the pathway. And I felt the pathway is very important because of certain precautions we need to be careful of. I'll talk about the side effects. Side effects, flu-like illness, nausea, vomiting. This is 10% of the population. Blood hematologic adverse effects, the GI and liver are also involved. That's why they do complete blood count, they do liver function tests, they do monitoring for these patients. Again, في عنا hepatotoxicity or suppression of the white blood cells because that's what it does. يعني الazathioprin, it's good and bad. This is very important, guys, because immunosuppression to a certain level that is needed is perfect. If we do too much immunosuppression, we're in trouble. This is important why? Because I'm going to be talking about the mechanism of action. The azathioprine is a prodrug. It's being activated to something called 6-mercaptopurine. The 6-mercaptopurine can go through 3 enzymatic activity, exactly like, so the first one is called 6-thiouric acid through an enzyme called xanthine oxidase. ذكروا, I'm going to ask questions, okay? The second, through an enzyme called TPMT, very important enzyme. It's called thiopurine methyltransferase. Thiopurine methyltransferase. It is written بالslide leisure, so you don't need to write. And both products, they are نحن بنقولهم non-toxic. Non-toxic byproducts. ما بناخذ عليهم. The third round is 6-thioguanine. And the enzyme that is needed here, it's called hypoxanthine phosphoribosine transferase. And I don't ask you to memorize enzymes as I don't myself, and I had to read it. Okay? But that product is basically involved in what? It's involved in being incorporated. Whatever has been formed here, the 6-thioguanine, it will be incorporated into the nucleotides in the DNA and RNA, leading to what we call suppression of proliferation. This is very important. Look, I'm putting the time and effort into it. Now, so this to help you to understand is that if I have the 6-thioguanine, then it will be forming a fake purine, which will be the DNA will notice that I can include you, you look like something I know. When it's incorporated, then, okay, there's something wrong, I can't continue with the DNA and RNA productivity. The cell, we know there's policemen in the cell, they will trigger apoptosis, death of B cells and T cells. Clear? Okay? Basically, this pathway involves 3 faucets. In order to look at it, there are 2 issues with this drug. The first issue is with the TPMT, thiopurine methyltransferase. Why? Because especially in Saudi Arabia, okay, there's a mutation in this enzyme. Okay, if this is a mutation, then it will not produce the 6-methylmercaptopurine, which is non-toxic. So look at it this way. If I have 3 faucets and I close one, the effort will go to the second 2. Okay, and mainly the one that will lead to suppression and or immunosuppression, so the immunosuppression will go, right? Contraindicated. So you need to screen for these patients who have this mutation of enzyme, and if they have this mutation, homozygous, has to be a homozygous mutation, you need to stop giving that drug. Kabish? The other thing is, look at this. Look at the enzymes. Anything rings a bell? Allopurinol rings a bell with xanthine oxidase. Allopurinol, what is allopurinol? Xanthine oxidase inhibitor type. If I give allopurinol and azathioprine, okay, so if I give allopurinol, which is a xanthine oxidase inhibitor, what's going to happen? هلا معناته that third arm is going to be blocked. And so the raw material, let's consider the 6 mercaptopyr is the raw material is going to be produced in the immunosuppression pathway. Clear? So again, this is contraindicated. معناته في عنا two things that we need to consider when we give azathioprine. We don't have the mutation of thiopurine methyltransferase, and we don't give allopurinoid. Clear? Second drug, خلصنا azathioprine, and we give it for pregnant women. So we give azathioprine for pregnant women, and we know the mechanism, we know the contraindication, we're good. Celsa is mycophenolate mofetil. What we need to know, it's another antipurine drug, but teratogenicity is very high. It's more tolerable than azathioprine, and actually it's very preferable by doctors, let's say. Okay? So, same mechanism, and they inhibit B cells and T cells. Also, like other steroid-sparing agents. عرفتوا ان steroid-sparing agents شو هن؟ كلهم azathioprine, mycophenolates, mofetil, cyclosporine, tacrolimus من الاسم steroid-sparing immunosuppressant. Okay. The onset is earlier. That's what's good about mycophenolate. Azathioprine takes a long time. Mycophenolate less. And faster, and it's well tolerated. Okay? Now, cyclosporine and tacrolimus, حطيتهم مع سوا. They're all together. They're a standard regimen. Part of the standard regimen. Yani that's why I highlighted standard regimen for all the drugs included. They inhibit calcineurin and selectively block transcription of interleukin 2. The calcineurin إيش هن؟ They produce what? Calcineurin inhibitors. Calcineurin إيش? No. Calcineurin, they are in the immune system, they produce cytokines. So the onset, في عندنا renal toxicity بالcyclosporine, we don't really see it بالtacrolimus, okay? Both tacrolimus and cyclosporine are less favorable because of toxicity. That's it. Yes.
Slide 22. Yeah, about
So calcineurin, if you go here, so it has to do with the pro-inflammatory cytokines. Look, role of calcineurin suppressing synthesis of pro-inflammatory cytokines. If I block calcineurin, I decrease the release of cytokines. Kabish? Yes. Next. هلا we are done with the standard therapy. خلص بطلنا standard. احنا مش standard. Biologics في احنا قلنا approved and used off label. الapproved اللي هو eculizumab. أكلة أزيمة أو زيمة. Okay? It's a monoclonal antibody against complement C5. Okay? وcomplement C5 هن اللي important role in innate antibody. Okay? And basically they attack the cell membrane. يعني هن part of the inflammatory killing of the acetylcholine receptors. Okay? Because they basically activate inflammation and cell membrane damage. And it's the first drug to be approved for refractory myasthenia gravis. This is standard refractory myasthenia. The other drug is off-label. So the other drug is off-label, rituximab. Rituximab, by the way, is a very important drug for the cancer treatment. We have something called non-Hodgkin lymphoma. It's doing wonders. It's really, really good. So they found out that people who have non-Hodgkin lymphoma and have myasthenia gravis, the myasthenia gravis improves. So that's why they took it. The second level they started using. Okay? What it does, basically, rituximab, they go on the B cell, CD20, and they attack the CD. Last thing is the urgent treatment for temporary relief. Again, I'm repeating myself. The first one is
IV immunoglobulin, okay? And they are fast. In 1 to 2 weeks, we see the improvement.
Second, when we talked about immunosuppressant, we said 12 months, 6 months. Look, the amount of time you have to wait for. So in surges of myasthenia gravis, we might use, and it can come really handy, the intravenous immunoglobulin. Okay. So when do we use this? Yeah, when we say urgent, طب when urgent? Explain to me. Myasthenia crisis لما يكون في عندي dysphagia مش قادرين can't swallow في عندنا weakness بالmuscles في عندنا respiratory failure. Okay. Preoperative before thymectomy or other surgery. I said this earlier, so this is repetition again. And to maintain remission that's not well controlled despite the use of chronic immunomodulating. Plasmapheresis, it's plasma exchange, and they remove acetylcholine receptor antibodies from the circulation. Okay. Before I end, there are drugs. Look, the picture. Unmask myasthenia gravis. They unmask. What are these drugs? Aminoglycosides. So the first drug is أول شيء neuromuscular junction blockers. The neuromuscular اللي هن neuromuscular blocking agents اللي بيستعملوهم بالanesthesia. They give neuromuscular blocking agents, succinylcholine. This is not to be given for people with myasthenia gravis. Aminoglycosides, antibiotics, aminoglycosides. Okay? It's teratogenic, صح؟ امبارح على التوك ولا قبل امبارح؟ Fluoroquinolones كمان بيعملوا لي muscle weakness. Magnesium sulfate. Magnesium sulfate. هلا tell me, when do we use magnesium sulfate?
هلا لانه انا بطلت امشي موقف when do we use magnesium sulfate؟ ها؟ magnesium sulfate. ها؟ It's not the one. Magnesium, yes, but I want something like magnesium sulfate. When? Magnesium sulfate.
Preeclampsia.
I think it is before I end, it is a rule of thumb. I think there's other drugs. Beta blockers, calcium channel blockers, by the way.
People have hypertension, they try to avoid beta blockers, calcium, يعطون methyl dopa instead. يعطون methyl dopa as an alternative كمان. They have been found to unmask myasthenia gravis. But the general rule is that every drug you should be careful. You should not. You should always tell what are the drugs. You should always monitor. Any medication may exacerbate myasthenia gravis. Before I end, you know Davis. They used to take Davis from place. يعني كانوا يقولوا له very مخوف. No more. يعني هاي myth لأنه هلا these are under control. Myasthenia gravis patients are under control. Minimal adverse effects, great quality of life. So I think in the future